Welcome to MedEvidence, where we help you navigate the truth behind medical research with unbiased, evidence-proven facts. Hosted by cardiologist and top medical researcher, Dr. Michael Koren.
Hello, I'm Dr. Michael Koren, and I'm here to lead another session of MedEvidence in our series of two docs speaking with each other. And I'm really fortunate to have a kindred spirit here, Dr. Christopher Labos from Montreal, Canada. And he and I are kindred spirits because we're both cardiologists. We both believe in evidence-based medicine, and we both have a way of critical thinking and describing our critical thinking such that we engage patients and help people understand the truth behind the data, which is the mantra here at MedEvidence. So, Christopher, thanks for being part of this program. Why don't you let people know a little bit more about yourself? And you have a fascinating background. I enjoyed learning a little bit about you, and share that with the audience.
Sure. So my name is Christopher Labos. I like long walks in the rain, cold autumn days by the fire, drinking hot
and pina
chocolate.
coladas, and pina coladas, right?
So I'm a cardiologist by training. That was my clinical training. And then something really shocking happened to me during my clinical training when I was going through residency. I kept asking people, because I was really interested in research. And I was like, well, how do you do research? Like, how do you do it? And they were like, oh, you have to recruit patients. Like, okay, but then how do you do it? Like, how do you actually analyze the data? Once you do this chart review, like, what happens? And I realized that for a lot of people, they would collect all this data. They would fill out an Excel sheet. They would go into this black box, and then these magical numbers would come out, and nobody really knew what they meant. And I started saying, like, well, how do I learn how to do research? And one of the cardiologists at McGill, where I did my training, was also had a PhD in epidemiology. And he said, well, if you want to do that, you should do a degree in epidemiology so you can understand how it works. And so after I finished my residency, I then went back to school to do a master's in epi, which was really fun because everybody in the class was 10 years younger than me. And they were, they were there with their laptops, and I was like, with my Star Wars notebook taking notes. And then I realized, oh boy, I really got to update because I hadn't been in class for like a decade at that point. And so I started learning about epidemiology and statistics, and I was like, oh God, they did not prepare you for this, right? They did not prepare you for this at all. And it was a really awakening, like an eye-opening experience, because I ended up, learning a lot about how research works, but I also learned a lot about how research goes badly. And sort of the light bulb moment for me was we were in class and we were learning out things like about absolute risk reduction versus relative risk reduction. And I was like, well, this is really interesting. And then this article came out about, and it was sort of one of the studies that came out of Framingham, I think. And it was one of these, fairly standard things. They sent out a food questionnaire, and it was about strawberries and berries. And they found that women who ate berries were at a 22% reduced risk of cardiovascular disease, which is, you see studies like that all the time. And I was looking at it, and then I said, oh, with my newfound statistical knowledge, let me crunch the numbers. And it turned out that you had to take like 86,000 women and like force feed them strawberries every day for 2 years to prevent one non-fatal heart attack. Right. And so, when you frame it that way, probably not the most important public health intervention we're ever going to, accomplish.
Right, yeah.
But I wrote and I was like, I need to do something about this. And I wanted to get involved with science communication and media. And one of my colleagues, his parents were journalists. And I said, what do you think I should do? He's like, well, why don't you just send a letter to the editor of the local newspaper? I'm like, will they publish that? And they were like, absolutely. And so I wrote a letter to the editor about the whole strawberry thing and absolute risk reduction, why we need to understand food research better. And their response was, oh, this is really interesting. Can you cut out 3,000 words and then we'll publish it in the newspaper? Right. And they did. And I was like so excited. I put out about 7 copies. I got copies for my parents and a little scrapbook.
Yeah, nice.
And emailed them, was like, are you interested in can I write others? And they were like, sure, we're not going to pay you, but go nuts.
Sure.
And so I started writing letters to the editor, and then that became a regular column. And then the column became radio segments, and the radio segments became TV segments. And so I started doing that regularly. And then, COVID hit. And all of a sudden, you needed medical experts. And because I had a track record and they knew they could rely on me, because I had a good camera and microphone setup like you're seeing all now, I started doing the COVID updates, because a lot of it at the beginning was not really infectious disease knowledge. It was about interpreting data and knowing how to separate out the wheat from the chaff.
Right.
And, it was just about telling people, it was like, I wouldn't really rely on this. This is kind of sketchy information. This is where the good information is coming from. And so a lot of it, sort of exploded during COVID. And then I started doing a whole bunch of other things for Medscape. And it just sort of started branching out into all kinds of science communication venues.
Nice. Beautiful. Well, you do a terrific job. So thank you for helping to educate the public. So let's jump into some of the things that you mentioned. So, you mentioned statistics, so we'll jump in statistics because I think that's really important.
I think we're going to lose all the viewership
we're gonna lose
now.
it.
We're going to talk about statistics. Click.
Right. Well, I was going to hold up back on that until the end of our conversation, but while we still have people's attention, maybe we should get into that a little bit. So I like to start with the Mark Twain line. You might have heard this, is that there are 3 types of mendacities: lies, damn lies, and statistics.
Yeah.
And you brought up a good example of it where you read something, 22% reduction in mortality, and it turns out that that's 3 patients over 80,000 people. So obviously not meaningful, and you're getting into the concept of relative risk reduction, which is the 22%, versus absolute risk reduction is the number of people who are affected. So that is a great point, a fabulous point that people don't always particularly understand well. But that's a good question to ask. And the easiest way to ask absolute risk reduction is simply how many people out of 100 will benefit from this.
Yeah. And that's an important point. And listen, there is, again, not to become too nihilistic, there is a reason why relative risk reduction is used in most scientific research. Is that's how the math works out, right?
Right.
And I think this is also important because it's very easy. It would be very easy for me to come on shows like this and be like, all medical research is wrong. And there have been some people during COVID, very prominent physicians, who are like, everybody is wrong except for me. I would do a much better job than Anthony Fauci. Or like, yeah, okay, calm down there.
Exactly. Yeah.
So there is a reason why relative risk reduction is used. There is a reason why odds ratios are sort of the standard and risk ratios are used less, even though odds ratios are not as useful clinically because they don't have the same type of interpretation, right? There's reasons why stuff became the default. There's reasons why frequentist statistics became the default over Bayesian stuff, and we can talk about Bayesian statistics later.
So let's just define some of those things for the audience a little bit. So just, an odds ratio is sometimes used because it's the odds of one thing happening versus the odds of another thing happening, but accentuates benefits or harm.
Yeah.
And so from a practical standpoint, it could look like something is much better than in fact it is.
Right.
Whereas relative risk is going to be less accentuating, and absolute risk reduction is going to be the most way of looking at what the true benefit is. So just giving people that concept.
Yeah, and the fascinating thing is that all of these things are correct, right? It's not as if one is wrong. It's just that they don't mean what you think they mean. Right. I mean, for people who don't know what people think the words odds and risk are synonyms, they're not, right? If you had a dice and you rolled the dice, and I ask you, what is the risk that you're going to roll a 4 on that dice? You would say it's 1 in 6 because you have 6 sides and one of them is the one you're at. And then, what are the odds of rolling a 4 though? Most people don't know the answer to that question. The odds of rolling a 4 on a dice are 1 in 5 because it's 1 positive event divided by 5 negative events, right? The 5 sides you don't care about.
Right.
Both of those are correct. It's just that our brains are not hardwired to think in terms of odds. Statisticians think in terms of odds. Bookies think in terms of odds.
Right.
But the general public doesn't. So if you publish a paper with an odds ratio, you might get an odds ratio of 3. And if you were to do the risk ratio would be 2. The odds ratio is always going to be more extreme than the risk ratio. And there's a hilarious example of that in cardiology, actually, where they went to the, I think it was an American Heart Association meeting. It was one of the major conferences where they asked a cardiologist, like, would you send this patient for an angiogram? And they answered yes. But they found that there was a discrepancy, and they were having actors read scripts. And so there was a discrepancy between the white actors and the black actors. And he said, well, there's a racial bias in cardiology that we need to address, which is a fair point. And it's actually a true statement. But then somebody says, like, yeah, but you reported the odds ratio. The odds ratio was 0.6, like a 40% difference between the white and the black actors. And well, if you look at the risk ratio, it's actually much less pronounced. It's still an issue, but you sort of, and so it's really important to really understand the significance of the statistics that you are using, because, there's lies, there's lies, there's damn lies, and there's statistics.
Right.
statistics can be misused in the same way that anything can. And so it's important to have an actual good mathematical grounding so that you know what you're talking about, because you could unintentionally make a problem seem worse than it is, or make a drug seem better than it is, just by using the wrong statistical test to get your message across.
Right. So the take-home point here is that when you hear odds ratio, there's a possibility that it's exaggerating the effect a little bit, more so than relative risk. And the most conservative concept, again, is the absolute risk reduction. And so that's a great take-home message for most physicians, quite frankly, and for patients. And so those are the kind of questions that you should be asking, or at least thinking about when you look at a study result. So you also use the term frequentist versus Bayesian, and we had a little conversation about that before. Yeah. And I think, again, it's a foreign concept for most physicians, quite frankly, and maybe it's worth a couple of statements on that. Do you want to dig into that? We'll dig into that a little bit together.
Sure. So, I mean, this is going to take about an hour, so settle in.
We want the 3-minute version.
Okay. I assume this was like the Joe Rogan podcast, and we would go for 4 hours.
Yeah. We don't smoke pot during these broadcasts,
okay,
so sorry. It's not legal yet in Florida, although that may change in November.
Oh, okay, interesting. There you go.
Another reason to come down to Florida.
Yeah. Okay, I'll give you the 3-minute version of what Bayesian statistics are. For anybody who's interested, there's a great book that I got. I think I got it as a gift, actually. It's called The Theory That Would Not Die. Mm-hmm. So if you're interested in a not mathematical explanation of what Bayesian statistics is, with a historical background and some very simple examples, I think it's a great book because it's very accessible. It's called The Theory That Would Not Die. I can't remember the author. I read it quite a few years ago. I thought it was really good. Bayesian statistics, named after Lord Bayes, who was an English reverend of all things.
Yeah.
It's the way of looking at data. The way most statistics work is you have a theory and then you try to disprove it, right? So you're basically saying, when you take the p-value, which is the statistic that we use in most medical research analysis, the p-value, first of all, nobody can actually give you the correct definition of a p-value because it's so convoluted. And it's basically this. I'll see if I can get it in one shot. The p-value is the probability that you would observe the data that you did, or more extreme data, if the null hypothesis was true. So if there was no difference between the two medications that you were studying, if there was no difference, the probability that you would see the data that you got in your experiment is the p-value.
Correct.
So if the p-value is very, very small, you're like, it's very unlikely that I would have gotten this data if the theory was untrue.
Right. Yes, absolutely. You said that beautifully. That was perfect. That was perfect.
There you go.
And then the convention, of course, is that we talk about a p-value of less than 0.5 as meaning significance, meaning that the likelihood that occurred by chance is 1 in 20. But we know there's a lot of caveats to that, and there's a lot of discussion around that concept. But that was beautiful. I love that.
Yeah. And here's the thing, that p-value is sort of very arbitrary. I mean, it goes back to Ronald Fisher, who just kind of picked a number, and he's like, I don't know, 5%, and it just became standard for no reason, right? And there's no reason why we can't lower that threshold. Yeah. But the whole premise of that field of statistics, which is the standard across most of medical research, is that it's frequent statistics. It's saying if the theory is true, or if the theory is untrue, depending on how you want to look at it. But that's not what we care about. We want to know whether the theory is true or not. So Bayesian statistics goes about it the other way. Rather than starting with a premise about the theory and then looking at the data, you look at the data and you develop your theory. And it says, given the data that you have in front of you, what is the probability that your theory is true?
Right.
It's a different way of analyzing the data, and it's actually a much more logical way to interpret the data, because it's sort of the difference between sensitivity, specificity, and positive, negative predictive value. Right? So for people who are familiar with these terms, you're going to get a basic primer in epidemiology now. The sensitivity of a test says, of all the people who are sick, how many of them will test positive? That's the sensitivity. And specificity is, of all the people who are well, how many of them will test negative?
Right. So Christopher, from a clinical medicine standpoint, we usually use a Bayesian approach. So for example, somebody comes to the emergency room because they're short of breath. They're coughing. They have a fever. We do a chest x-ray, and we think we see pneumonia on the chest x-ray, and we diagnose that patient with pneumonia. But we know that chest x-ray is an imperfect tool.
Right.
But in this setting, what it does, it moves us from the presumption of pneumonia to, quote, the official diagnosis of pneumonia, although there could still be some level of doubt.
Right.
Flip side being is if that patient came in and had fractured their foot, and you got a chest x-ray and they have absolutely no symptoms, and the chest x-ray comes back and says pneumonia, you would be very skeptical about it. The exact same chest x-ray, but you're just moving the needle in terms of what the truth is, not actually deciding that that is the truth. But that's the way clinical medicine works.
Yes.
Whereas clinical trials works in the frequentist way that you were explaining, whereas you say, okay, we think that this is the, quote, null hypothesis. This is our hypothesis, and we're going to get a number of patients that come in that help us determine is that true or not true based on this standard of evidence. And
yeah. And I think what's fascinating is that there is a shift to make statistics more Bayesian. And in fact, there's nothing that stops you from using Bayesian statistics in a clinical trial. And I've seen a few of them. They're not very common. And that's because a lot of people are unfamiliar with Bayesian statistics. And it's also because up until like the 1980s, the computers we had were just not powerful enough to do Bayesian analysis. The great, wonder of frequent statistics is that you can literally do it with pen and pencil, right? And that's what a lot of people do. Yeah. So I think Bayesian statistics, because again, just to give you another example that, you said the X-ray one, another perfect example is stress testing, right? Just because the stress test is abnormal does not mean the patient has heart disease. It really depends on the pretest probability. If you have a positive stress test on a young woman with no risk factors, well, that's almost certainly a false positive. Whereas if you have a positive stress test in a, middle-aged man who's a smoker and has high blood pressure, well, then it's very likely that they have heart disease. And that's the problem with frequent statistics. It does not incorporate the pretest probability into the analysis, whereas Bayesian statistics does. And that's why I think it's so fascinating for me. And it's much more intuitive because Bayesian statistics is how we practice medicine, and yet frequent statistics is how we analyze data. And that, I think a lot of people don't fully appreciate why that is so conflicting.
Yeah,
an idea.
It's confusing. It's really confusing for people from a number of standpoints. The flip side is that people will bring in a report that says, rule out lung cancer in, a 20-year-old who's a non-smoker because they saw something on an X-ray that got them upset, and you have to, and you're not acting upset. So why you're not acting upset? That's what this study shows, and we have that insight. That's what the physicians have, is that insight to not be particularly concerned about it based on this concept, this Bayesian concept. So really fascinating stuff. So let's take a break now. And I also want to talk to you a little bit about your book, which I thought was fascinating, and a few examples from the book about how easy it is to misinterpret data and how important it is to understand these concepts so that you can make good medical decisions, which is really what our MedEvidence platform is all about.
Thanks for joining the MedEvidence podcast. To learn more, head over to medevidence.com or subscribe to our podcast on your favorite podcast platform.